Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki ekoweshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
Bienvenue. Bonjour. Welcome and good morning, everyone, to the April edition of Family Medicine Grand Rounds. My name's Doug Archibald. I'm the Director of Research for the department, and it's my pleasure to be the moderator of today's rounds. We have two fabulous presentations lined up and three presenters. I'm going to introduce all three presenters, and then Elise and Jennifer will begin with their presentation. So first of all, Dr. Elise Azzi is a family physician with a special interest in sexual and reproductive health. She completed her family medicine training at the University of Ottawa in 2018, followed by the Enhanced Skills in Women's Health program in 2019. Since 2022, she's served as the Director of Women's Health in our program, the Enhanced Skills program. And in addition to her comprehensive care practice, she provides specialized care as a consultant at the Ottawa's Sexual Health Clinic and the Ottawa Fertility Center. Dr. Jennifer Mitchell is a family physician with a special interest in reproductive health and medical education. She completed her family medicine training at the University of Ottawa in 2022, followed by the Enhanced Skills in Women's Health program in 2023. In 2023, she worked for the Children's Hospital of Eastern Ontario, Pediatric and Gynecology Department, and she also locumed as a family physician. She's now a staff physician practicing comprehensive primary care at the Ottawa Hospital Academic Family Health Team at the Riverside Unit, where she also provides specialized women's health care. That'll be our first presentation. And then our second presentation will be by Dr. Sophie Turcotte, a family physician practicing in Ontario and an early career researcher affiliated with the Institut de Savoir Montfort. After completing her family medicine residency program at the Montfort Hospital, she's currently completing U of O's Advanced Skills program for clinician scholars under the supervision of Dr. Sharon Johnson. Her research focuses on improving access to primary and mental health care, virtual care, and health care for francophone minority populations. So I'm now going to turn things over to Elise and Jennifer for our first presentation.
Awesome. Thank you so much, Doug. Can you guys see my screen?
Just fine.
Perfect. So we are presenting the results of our study, the impact of the Enhanced Skills Program, showcasing the 20-year outcomes of the uOttawa program that trains family physicians as experts and leaders in women's health. So as Dr. Archibald mentioned, I'm a family doctor with focused practice in reproductive health, and I work as a director of women's health and as an assistant professor for the Department of Family Medicine.
And thanks, Doug, for that introduction. So I'm Jen Mitchell. I'm working at the Riverside Family Health Team, and I'm a former grad from the program from 2023. So we have no commercial conflicts of interest to declare. Dr. Azzi does receive compensation from the Department of Family Medicine for her role as Director of Women's Health. So at the conclusion of this session, participants will be able to, 1, describe the structure and key achievements of the University of Ottawa Enhanced Skills Women's Health Program, 2, evaluate the 20-year impact of the Women's Health Program on clinical practice patterns, leadership roles, and healthcare delivery, 3, analyze the challenges faced by graduates and the barriers to implementing focused women's health practice in primary care settings, and 4, identify next steps for establishing a model of excellence in specialized women's health care and primary care training.
Let's start with talking about what the Enhanced Skills in Women's Health program actually is. So we are a 12-month full-time residency training program funded by the Ontario Ministry of Health and Long-Term Care that covers clinical, educational, advocacy, and research components related to women's health across the lifespan. The curriculum is personalized, allowing residents to tailor their rotations based on individual career goals and areas of interest while maintaining core women's health competencies. The program was established in 2004-2005 and has successfully trained close to 40 graduates. Our mission is to train family doctors to become healthcare leaders and experts in women's health. 20 years since the program's inception have led to 37 graduates, all listed on this journey map, a testament to the growth and sustainability of the program, as well as the steady enrollment of learners over the years. While the program has historically been allocated funding for only 1 resident per academic cycle, we have been quite creative in successfully graduating between 1 and 4 residents per year. In April 2025, we have 4 active residents, 2 Canadian medical graduates, 1 PGY3 in family medicine, 1 PGY5 in the Royal College Emergency Medicine Program, and 2 visa-sponsored family medicine residents from Saudi Arabia. Who are the Enhanced Skills in Women's Health graduates? We are a family medicine training program, but we have taken on a number of Royal College residents under our wing. 86.5% of our graduates are members of the CFPC, 13.5% of our graduates are members of the Royal College. The Royal College programs included obstetrics and gynecology, dermatology, psychiatry, and emergency medicine. Where are our graduates now? Based on the data publicly available on the Provincial College of Physicians and Surgeons websites, 85% list Ontario as their primary practice location. 6% are in BC, 3% in Alberta and Quebec respectively, and 3% were visa-sponsored trainees that have returned to their home country after graduation. This slide reaffirms that the funding that Ontario Ministry of Health is investing into training women's health experts is primarily benefiting Ontario patients. Of those 85% that are still in Ontario, 79% list Ottawa as their primary practice location. 21% are in Toronto. This is a very important statistic we would like you to keep in mind as we go through this session, as it will help explain how our program has been able to grow significantly over the last 20 years, due in big part to our ability to train and retain a large portion of our graduates that have generously continued to give back to the program through involvement in education, scholarly work, and mentorship. What does the Enhanced Skills look like in 2025? This is a sample rotation schedule of our current residents. This is, we have a total of 13 blocks in a 12-month academic cycle. Through their fellowship year, the CFPC residents are expected to complete half-day backs in family medicine to keep up with their comprehensive family medicine skills. They're also expected to attend academic days, complete scholarly activities, and be engaged as medical educators themselves. We allocate at least 4 rotations to what we call the Women's Health Core Service. These rotations include adult gynecology, menopause, vulva specialty clinics, breast health, sexual health, and sex therapy. And the majority of these rotations are community-based, taught by family doctors with focused practices in women's health. Our residents then rotate with the pediatric and adolescent gynae at the Children's Hospital of Eastern Ontario and choose from a number of selectives and electives that align with their interests and career goals. That could include anything from family planning and abortion care, perinatal mental health, infertility, adolescent medicine, gender-affirming care, etc.
All right, so moving on to impact study objectives. So the study was conducted to assess the long-term impact of the Enhanced Skills Women's Health Program. So one, we wanted to understand the motivation that led these residents to choose to pursue the Enhanced Skills training at the University of Ottawa. We wanted to explore practice patterns and investigate how the program influenced the career trajectories of its graduates. We wanted to assess leadership roles that the Enhanced Skills graduates have taken on in clinical, academic, and advocacy roles, and also determine program impact. So assessing the benefits and strengths of the program and whether or not we're meeting our training objectives. So our hope is that these findings will help support future growth of the program by identifying areas for improvement to strengthen the program and address any gaps in training. So before we actually started to dig into our own program, we completed an environmental scan by looking at all the Enhanced Skills Women's Health training programs across Canada as of 2022. So we found that there are only 4 universities in Canada that offer a comprehensive women's health program, which is specifically different from the obstetrical skills or maternity and newborn care programs, which are also enhanced skills programs within the CFPC. So those 4 schools that we identified were, the University of Ottawa, Queen's University, the University of Toronto, and the University of British Columbia. So the duration for these programs varies between 3 to 12 months, and the University of Ottawa offers one of the longest and most comprehensive programs. So as such, we identified that the Enhanced Skills Women's Health Program at the University of Ottawa is one of the few designated women's health programs in Canada that embraces a broad range of women's health issues beyond just the reproductive health cycle. So after the environmental scan, we determined that our study population would be the known Enhanced Skills Women's Health graduates between 2005 at its inception and as of 2023. At the time, the department provided us with a list of 26 graduates on record up until 2023. However, during the study, participants helped us uncover an additional 5 graduates that were missed from the original list from the Department of Family Medicine. 22 of the 26 graduates responded and agreed to participate in our study, so that was about an 85% response rate. We were unsuccessful in communicating with about 5 of the 31 past graduates. Interviews were conducted via Zoom, and those unable to participate in a Zoom session were offered email correspondence instead to ensure that their data was captured in the study. An interview guide was developed with questions aimed at soliciting qualitative data to answer the research objectives. Of note, our submitted project was submitted to the University of Ottawa Research Ethics Board, and we were deemed exempt under Article 2.5, the Program Value Assessment. The participation in the study was completely voluntary, and the transcripts of our interviews were de-identified. The transcripts were then reviewed individually by 2 researchers to establish conceptual codes, patterns, trends, and underlying themes using the constant comparative method. So standard inductive coding techniques were used to interpret the key themes that emerged from the data.
So what did we find? Considering our program did not have a standardized curriculum since its inception, we wanted to understand what this fellowship looked like for each of our graduates. What rotations did they complete? Did they all even have a similar experience for the Women's Health Fellowship training? While the program was elective-based, it was noted that interviewed graduates all adopted a very similar overall approach to planning their PGY3 year, with many common overlapping rotations. This slide represents all the reported domains or rotations identified by the participants displayed in the vertical bar chart, sorted from highest to lowest, and then the percentages on the horizontal axis. We will zoom in to see better. And so, as you can see, the most completed domain is the adult office gynecology. The other highly selected domains included pediatric gynecology, perinatal mental health, rheumatology, family planning, gender-affirming care, etc., down to medical subspecialties like endocrinology, obstetrical medicine, dermatology, and less commonly, refugee and immigrant health, infectious diseases, and addictions. This broad range of clinical domains reflects an understanding by our trainees that women's health extends beyond reproductive health to encompass the full spectrum of gendered health experiences, acknowledging that health issues manifest differently or disproportionately in women due to systemic inequities, social determinants, and lived experiences. So a few quotes from our study. There was nothing that I learned in that third year that was useless. I always took away something that I still think about even 10 plus years later. Another graduate said, I would say a PGY3 in women's health is equivalent to 5 to 10 years of self-taught CME in the field.
So moving on to the benefits of the Enhanced Skills Women's Health Program, when asked what kinds of tools did the PGY3 year equip you with that you would have otherwise not have received in core family medicine residency, and what the benefits do you think the Women's Health Program graduates bring to their communities, the participants responded as follows. So the most widely acknowledged benefits are 1, gaining a unique and enhanced skill set, and 2, increased competence and confidence. A substantial majority recognize the value of the program that it brings to both patients and the healthcare system. Over 3/4 of participants noted that the program helps increase accessibility, reduce wait times, and offload non-surgical cases from gynecological services, while some saw it as a bridge between family medicine and gynecology. Other identified benefits were understanding patients outside of the reproductive role as family physicians, creating medical educators and health advocates, as well as building connections that help the graduates navigate the healthcare system more efficiently. So to quote another graduate, the experience and knowledge graduates acquire is invaluable in placing them in a unique position to take on teaching roles, clinical roles, program enhancement roles, administrative roles, advocacy roles, research roles, etc., to ensure that all women from puberty to beyond menopause get the validation, information, and care they need and deserve. When asked why they chose University of Ottawa for their women's health training, the participants identified the following strengths of the program. So the majority of participants highlighted the program's flexibility, which allows trainees to tailor their learning experience to align with their specific career goals. More than half appreciated its self-directed nature, and many valued access to specialized women's health consultants. Other strengths noted included the program's uniqueness, the supportive learning environment, and the 12-month duration, and the opportunity for bilingual clinical exposure as well. Overall, the Enhanced Skills Women's Health Program's strengths lie in its customizable structure, extensive clinical exposure, and ability to foster leadership and advocacy in the field of women's health. Our program is versatile and aligns with the diverse learner needs. Oh, I think you're muted.
Sorry. One key objective of the study was to understand the impact of the program on the career trajectory of our graduates. And one major area of interest was to uncover whether this program was influencing our graduates to focus their practice rather than continue working in comprehensive primary care. Interestingly, over 3/4, so 76% of the CFPC participants reported having a mixed family medicine practice that incorporates women's health as a niche area of interest. So only 24% are practicing women's health exclusively. The study found that our graduates pursued diverse career paths, where in addition to a mix of family medicine and women's health, they worked at sexual health clinics, provided family planning, community health centers, obstetrical care, surgical abortions, postnatal and infant care, and breast health. Other focused areas included colposcopy, lactation medicine, adolescent gynae, and palliative care. Another quote, "It is my experience as a family doctor that's made me a really good specialist in breast health. I know my audience. I am my audience," right? Have we created leaders? 91% of our participants stated that they serve as the go-to women's health experts in their clinics and their communities. 41% are involved in community leadership and advocacy. 23% hold leadership positions in provincial and national organizations. 9% develop outreach programs such as sexual health podcasts and educational resources, and 4.5% participated as authors in national guidelines. Have we successfully created medical educators? 77% of our interviewed graduates serve as clinical preceptors and mentors for medical students and residents. 50% of our graduates have participated in academic teaching, delivering lectures at medical schools and CME conferences. 23% have contributed to research and publications in women's health.
So then what are some of the challenges faced by our graduates? One of the biggest challenges Enhanced Skills Women's Health graduates face are billing restrictions, particularly in Ontario. So due to the current primary care capitation remuneration models and outdated diagnostic codes, 73% of our graduates identified billing challenges as a major barrier to practice. They also cited inefficiencies in the process of obtaining a GP-focused practice designation, which further hinders their ability to practice in the area of women's health. The Ontario Ministry of Health has not yet adapted billing codes to fully recognize the broad skills of the Enhanced Skills Women's Health training graduates. Thus, 18% note inadequate remuneration for women's health work amidst rising practice costs. So to quote another graduate, the Ontario Ministry of Health has failed to allow me to have a designated focus practice, which has impacted my ability to build to the value of my expertise and has impacted patient care access. A significant challenge faced by enhanced skills women's health graduates is the lack of formal recognition for their specialized training. And so the Enhanced Skills Women's Health Program is currently classified as a Category 2 program by the College of Family Physicians, meaning that graduates do not receive a certificate of added competence upon completion of the program. So 23% of graduates identified this lack of certification as a barrier to professional advancement and credibility. So to quote another graduate, "We don't have any extra credentials behind our names specifically for completing the PGY 3-year, but we have valuable skills and we save the system money." Limited practice opportunities in procedural fields such as surgical, abortions, and colposcopy was also identified by graduates. Some graduates reported struggling to find job opportunities in certain procedural areas that they were trained in due to certain political monopolization of the outpatient procedural ORs. Balancing full scope family medicine with a focused practice in women's health can be a challenge as well due to the state of the healthcare system today. And so to summarize, Enhanced Skills Women's Health graduates face systemic, financial, and professional challenges that hinder their ability to fully utilize their specialized skills. However, some graduates emphasize that the Enhanced Skills Women's Health training did not negatively impact their comprehensive primary care. So one graduate was quoted as saying, "It is no secret that doing what you love makes you a better provider. Being able to do both family medicine and women's health does just that. The PGY 3-year does not deter from family medicine. It allows us to build on it so we can prevent burnout." And another graduate said, "I know there is always this fear that enhanced skills residents will not have a comprehensive practice. We can exist together. Programs should be proud of these family medicine expert leaders they are helping to shape." When asked for feedback on how we can improve the program, participants identified the following. While many praised the program's flexibility as a strength, some did find it rather overwhelming. 14% highlighted the need for further structure to aid in standardization. So one graduate was quoted as saying, "The program is too unstructured. I think my objectives changed as I started the program. You gain more exposure to different things, which is why I think it would be a good idea to have more mandatory rotations, because you might not know the things you're interested in until you do them."
So in conclusion, has the uOttawa Enhanced Skills Program over the last 2 decades indeed achieved its mission of creating women's health experts and leaders within primary care? We see from the data in this study, as reported by our participants, that our program empowered them by enhancing their confidence and competence to meet the needs of their patients and their communities. They believe our program bridged gaps by integrating women's health principles and improving accessibility and reducing wait time. They think the program influenced their practice patterns, but importantly, 76% of our CFPC graduates still practice both comprehensive primary care and a focused practice in women's health. They state that our program helped them become leaders and medical educators, whereby over 90% are the go-to women's health experts in their communities, and 77% are involved in medical education. As such, we think that our program is realizing its vision of enriching patient care and fostering leadership in women's health policy and delivery. So where do we go from here? Our study participants have identified the key priorities moving forward. The Enhanced Skills Program should prioritize standardized accredited curriculum to achieve formal certification and medical recognition. Despite the flexibility, our graduates reported a cohesive clinical experience through pursuing very similar rotations. This confirms our vision of developing a well-structured curriculum while striving to accommodate individual learning goals through electives. By standardizing the curriculum while maintaining elective flexibility, we can start advocating for Category 1 status, formal certification at the CFPC level. Which leaves us with some food for thought. Can we attribute the graduates' career trajectory exclusively to the Enhanced Skills Women's Health Program? Is there interest from the other 3 programs in the country to collaborate on an accredited national curriculum? Does the CFPC even support the expansion of certificates of added competence programs? Are the Enhanced Skills graduates indeed bringing value and saving the healthcare system money? And are billing restrictions an intentional government policy to deter from focused practice? At what tables, whether local, provincial, national, or international, should these discussions and decisions be made? Sorry, my screen froze. There. Can you see my final slide? Finally, today, we celebrate the program's achievements by recognizing its successes and empowering its community. Two, we need to advocate for formal certification and recognition, as well as the elimination of practice barriers and billing restrictions. And finally, we want to develop the program vision with the goal of becoming a model of excellence in women's health training and setting national and international standards for training family physicians in women's health.
So one limitation of this study is the potential for bias due to Dr. Azzi and myself having been involved in the women's health program. And so future research should consider external evaluations to further validate our findings. And these are our references, and thank you.
Elise and Jennifer, thank you so much for that presentation. And congratulations on, doing this overview. I think it's really important for all our programs, to take a look under the hood and, see where things have come over the years, what things may need to get changed and modified and so on. If you don't mind, I'd like to start the questions. And I'd like to go back to your needs assessment, actually. And, I always find it interesting to find, well, okay, there's 4 programs across the country, but then there's so many institutions that don't have this program. And I was just wondering how you did the environmental scan. Was it just, publicly accessible materials on websites? Or, if you found that a program, you couldn't find something in a program, did you, explore why? I'm just wondering, does it take a champion in this area to get a program going, or is there more to it than that?
I think the first piece is to acknowledge that we as a society still view women's health as reproductive health. And so it's interesting that there are so many more maternity skills and obstetrical skills programs as +1s, but only for women's health. And to be more clear, there's only technically 2. Us in Toronto have 12 months. Queens has a 6-month residency. And we know that because they send their residents to us. So we shared a resident last year. So they're not a very well-developed program, and most of their training is outside of Kingston via electives. And then we also know that UBC has only a 3-month program, and their current resident emailed us recently because she can only fill out 6 weeks and has asked that we help. They told her to go to Ottawa because they know what they're doing there. So there's not really 4 programs, there's technically 2. And 2 in very early development. In terms of the environmental scan, I think Jen can comment a bit more on that, but we've both been involved in whether us applying to the women's health programs in the last few years, or being involved in the interview process for the enhanced skills programs, and going through the 17 schools, all the Department of Family Medicine websites, and looking at each to identify whether or not they have a women's health program, and really having our finger on the pulse, because we do interviews every year, we're aware of what is being offered in the country.
And just to build off that answer, it was interesting the language used for some of the programs. So it would be mostly like an obstetrical enhanced skilled program, but they might have like a 2-week elective in women's health. But it was like more focused on that reproductive role with a brief kind of period of women's health. So we looked at each medical school in Canada to identify a program that their vision was more of comprehensive women's health rather than a focused practice in obstetrical skills.
Thank you. Other questions, comments?
I see a comment about a question for pessary service. Did you mean training in pessary care?
Yes, like O'Shea here. Years ago, I used to do pessaries on people, and it seems to be a skill or a service that seems to have vanished. And I think it's still really important for the elderly women who are not going to get surgery because they got multiple conditions. And I wonder, do you guys provide that training or service or?
Yes, that is part of our adult, the core women's health program. They can rotate with the urogynecologists at the Ottawa Hospital, with the nursing team at the Ottawa Hospital that does pessary fittings. And then some of our community preceptors, for example, Dr. Rezaifar, et cetera, are involved in teaching. So while they rotate in their clinics, they learn how to both fit and care for pessaries.
I have a lot of male residents over the years, and I find that at the end of the 2 years, really some concerns. Often many have not done very many pap tests, and these are often doctors are going to be working in rural, remote areas, and I wonder, how do we enhance that training so as to maybe get them exposure to your services, or be a coach or a mentor to them?
Yeah, that's a very valid question. I think it's something that we struggle with because we always have to take patient consent as part of the process. And more often than not, we're finding that patients, due to various reasons, are declining having male residents in the room. And so we try to do it on a case-based basis, like ensuring that the patient understands the need for that and making sure that both the patient and the resident are comfortable. We are doing a lot more simulations to try to help our residents, whether it's through in their community locations or in academic day at the simulation center, to help them with the procedural skills to get them up to par with that. But I think this is not a unique issue. I think it's across the board that a lot of male physicians or residents are feeling less and less comfortable in performing women's health skills, but it's something that we are striving to figure out a delicate balance for that. And we'd be open to any feedback that you guys may have.
Great. Well, thank you very much, Elise and Jennifer. If people still have questions or comments, feel free to use the chat, and Elise and Jennifer will reply to you. And it's with great pleasure now that I can, I've already introduced Dr. Sophie Turcotte, but I'm going to hand things over to her for her presentation. Over to you, Sophie.
Thank you. Let me just share my screen here. Can you see? Can everybody see?
We can see it just fine, yes.
Great, perfect. So, bonjour tout le monde. J'espère que vous allez bien. Hi, everyone. I hope you're doing well. Thank you for introducing me. As was said, my name is Sophie. I'm a family doctor. I'm working in Rockland as well as at the Montfort Hospital. And as was said, I'm also an early career researcher. And so today, I'm going to talk to you a little bit about my research, especially my focus on integrating virtual care and specifically mental health care into primary care services. And I'm going to also talk to you more specifically about a program that was developed at the Montfort Hospital, which is a virtual healthcare step care program, which include a virtual platform that's called ēquilia. So I'll talk to you a little bit more about that during the presentation. You will notice that I will go from French to English during the presentation, so don't hesitate to interrupt if you need any translation or any specification. So first of all, just the objectives of the presentation, just to contextualize everything. I'm going to start with a quick overview of the mental health crisis in Ottawa and in Canada, and also how it affects the francophone minority in Ontario because of the lack of access to French services. Then I'm going to present to you the program at the Montfort Hospital, which I mentioned a little bit earlier, and specifically the ēquilia platform and the research program around that. And then I'm going to end the presentation with presenting my own research project that's part of the program on the platform, which aims to basically involve family physician in improving the virtual healthcare platform that the Montfort Hospital is providing to better integrate it in the primary care services and really promotes its sustainable and widespread use for patients, basically. Donc, je vais commencer, comme j'ai dit, par faire une petite revue de la crise de santé mentale en Ontario et au Canada. On le sait que c'est une crise qui perdure à travers les années pour plusieurs raisons. Donc, je vous ai mis quelques statistiques ici. Là, je vais passer quand même assez rapidement. On le sait qu'il y a un Canadien sur 5 qui souffre de problèmes de santé mentale. 5 millions de Canadiens qui sont diagnostiqués avec des problèmes comme une santé mentale, comme anxiété, dépression et problèmes d'abus de substances. On le sait que pour ces patients-là, en général, la première ligne de traitement, ça va être des traitements de psychothérapie. Malheureusement, chez les patients qui recherchent ce type de traitement-là, il y a moins de la moitié qui sont capables d'y avoir accès pour plusieurs raisons, les coûts, l'accès au niveau plus géographique, l'accès à des services dans leur langue, etc. On sait aussi que les problèmes de santé mentale peuvent beaucoup affecter la qualité de vie des patients, leur fonction au niveau du quotidien. Donc, environ 10% là, des patients souffrant de santé mentale qui sont reconnus comme avoir un disability là, qui affecte leur fonction, que ce soit au travail, dans leur vie de tous les jours. Puis ça affecte beaucoup leur qualité de vie, puis ça rajoute un fardeau au niveau de la prise en charge également. Il y a beaucoup de problèmes de santé mentale, mais la prise en charge est aussi difficile parce qu'il y a une crise de soins primaires au Canada et en Ontario. Donc, comme vous pouvez voir ici, il y a un Canadien sur 6 qui n'a pas accès à un médecin de famille. Puis on le sait que dans le cas de problèmes de santé mentale, la plupart du temps, le médecin de famille est vraiment le premier point de contact pour ces patients-là. Donc, c'est très difficile d'avoir accès à des soins si on n'a pas accès à un médecin de famille de façon dans un délai qui est raisonnable. Puis ça va mener à une surcharge au niveau de l'urgence. Fait qu'on voit qu'il y a beaucoup plus de consultations à l'urgence pour des problèmes de santé mentale et aussi une augmentation des hospitalisations parce que les patients attendent plus longtemps avant de consulter, donc arrivent à l'urgence avec des symptômes qui sont plus sévères ou ils arrivent en crise, donc ils doivent être hospitalisés à ce moment-là. Tout ça a des coûts économiques au niveau de la province et du pays. Donc, les coûts directs et indirects s'élèvent environ à 51 milliards de dollars par année. Puis ça inclut les coûts de santé, mais aussi les coûts de perte de productivité des individus qui sont atteints de problèmes de santé mentale. So if we talk a little bit about the francophone minority in Ontario, they do show the same kind of portrait of prevalence for mental health disorder, common mental health disorder, as the rest of the Canadian population. The difference for them regarding mental health disorders is that often they don't have access to services in French. So it's super difficult for them to have a good management of their symptoms because of that. So language, correspondent care is super important. And when it's not possible, it leads to consequences. One being that patients don't feel like there's a lack of compliance of patient usually with the management plan because they don't feel that they're understood by the healthcare professional, or patients will just not seek care because they don't feel like they can get access to the right care for them that will help with their symptoms. The other thing that we see through the research is that there's also decreased quality of care for a couple of reasons. So there's misdiagnosis, there's suboptimal treatment. And I also saw an article recently about, it was about like hospitalization and French-speaking patients that were hospitalized in psychiatric wings saw the psychiatrist less often. So they don't really describe why or if there was a consequence on the quality of care, but that shows that there's a difference in care for those patients. And it could be that the patient that was hospitalized just didn't seek any contact with a psychiatrist who probably didn't speak French or less fluently than them, or that maybe the healthcare professional was less comfortable with, interacting with that patient. So that leads to a decrease in the number of encounters during a hospitalization. So as we see with this quick overview, there is a need for the Francophone population in Ontario for resources for mental health disorders treatment. And this is why the Montfort Hospital has created the program that I mentioned earlier. I'm going to talk to you a little bit about that. You have the name here. So it's Programme de télésanté mentale communautaire par étape. So this is a program that's offered in French right now because it's for the Francophone minority. The goal will be eventually to expand it to English and to target the whole Canadian population or Ottawa population. So it's a step care program, as I mentioned before. So there's 3 steps, as you can see here. So basically, the patients are referred to the program, and then there's a first triage assessment to evaluate the patient's needs. They will fill the validated questionnaire, you know, the PHQ-9, GATE-7, to assess the intensity of their symptoms. And they will be attributed to either first, second, or third intensity intervention. The first intensity intervention consists of self-learning modules for patients to complete to be able to manage their symptoms. This is the ēquilia platform, which I'm going to talk more in details in other slides. Once they have completed this step, if there's no significant improvement in their symptoms, or even at first initial assessment, if the symptoms are too intense to complete a mild intensity intervention, they will be sent to a moderate intensity intervention, which consists of psychotherapy services, either individualized or in groups. And the third intensity intervention consists of psychiatric assessment for either diagnosis specification or to assess for possible medication. And this is also with more intensive psychotherapy here. And we do have like a multidisciplinary team right now. So there's a group of psychologists, and there's a psychiatrist that is also providing services for patients in this program. So the wait time are way less than in the community in general right now. So once patients complete those steps, or sometimes they stop after the first step, but we do have an encounter, like we do talk to them after that to talk about their experience and how they feel about the management they receive. Do they need other steps, and so on and so on. Regarding follow-up, so we have 2 ways to follow patients. It's either that our team will follow them, so our group of psychologists can follow them during the treatments, or it's the healthcare provider that referred them to the program that can follow themselves, like follow their patients. During the progression, especially during the ēquilia self-learning modules, the patient will complete the validated questionnaire I mentioned before to assess their progression and level of symptoms. If there's an increase in symptoms, even before they stop, like they complete the process, then they will be we will call them over the phone actually to see what's going on and how we can either step up the intensity of intervention or just adjust the intervention. There is inclusion and exclusion criteria to be able to be eligible for the program. Donc, je vous les ai mis ici. Je ne passerai pas en détail sur tous les critères, là, mais en gros, c'est pour la population adulte qui parle français, qui réside en Ontario. Et au niveau des pathologies qui sont ciblées, c'est certain qu'on veut des pathologies qui peuvent être traitées à travers les interventions qui ont été développées. Donc, pas des symptômes trop sévères et pas évidemment d'idées suicidaires actives à ce niveau-là. Donc, si je vais un peu plus en détail pour la plateforme ēquilia, donc c'est, comme je disais, des modules d'auto-apprentissage qui ont été adaptés, en fait. Donc, c'est des modules qui existent en Australie. C'est une plateforme qui s'appelle This Way Up. Puis les modules ont été adaptés au contexte canadien-français pour qu'ils soient, dans le fond, au niveau du langage et culturellement correct pour la population. C'est une plateforme qui est en français et les modules d'auto-apprentissage se font à l'intérieur de 6 à 12 semaines pour les patients. Ici, au Canada, donc la plateforme a été créée de façon conjointe entre l'hôpital Montfort et l'Université de Sherbrooke. Donc, c'est vraiment un projet conjoint. Les directeurs de la plateforme et du programme par étape à l'hôpital Montfort sont Dr. Jean Grenier, Dr. Dominique Gosselin, puis ils ont leur partenaire là, au niveau de l'Université de Sherbrooke. Et il faut comprendre aussi que la plateforme ēquilia, c'est oui un outil clinique, mais ça soutient aussi un programme de recherche. Donc, il y a différents projets de recherche qui sont associés à évaluer la plateforme, essayer de l'améliorer. Parce que oui, la plateforme australienne a été, tu sais, il y a eu des essais cliniques randomisés qui ont démontré l'efficacité là, pour la réduction des symptômes des problèmes de santé mentale communs, mais on veut s'assurer que au niveau de la plateforme ēquilia, ça c'est reproduit également. Donc, moi, je suis nouvelle sur l'équipe au niveau du programme de l'hôpital Montfort puis de la plateforme ēquilia, mais j'ai un projet de recherche qui est associé à cette plateforme-là que je vais vous présenter là, dans les prochaines slides. So, as I said, I have a research project around the ēquilia platform. So the aim, like I said at first in the presentation, is really to involve primary care providers to try and improve the platform, so it's better integrated in primary care services. So, you know, virtual and AI-driven solution for virtual, like for primary care are really like, it's something that's expanding right now, and it's like super impressive how it can help with, you know, decision-making, triage, and care in general. Usually what is missing is how to integrate it into primary care services. So we know family physician, they are overworked, they have a big workload, they don't have time to increase that workload. So when we think about virtual solutions, we need to have a strategy to make sure that it doesn't add to the workload. So it's that solutions are easy to use and will actually support family physician and not add to the complexity of the care. So this is kind of where I'm coming from for my project. I wanted to make sure that the ēquilia platform was meeting the need of the family physician, and that's why I want to involve primary care physician in its improvement. So we do have a funded project by the CNFS, which has just started. So I don't have any data to present to you, but I'm going to explain, like do a quick overview of the project. So you have the objectives here. So the first thing we want to do is just explore how family physicians see the current virtual resources that are available for them to support management of common mental health disorders in their patient, and what are the needs that are not met by those virtual resources. The other objective is specifically around the virtual platform ēquilia. So we'll basically show the platform to those family physicians that will be able to recruit and kind of have an interview about, well, what do you think about the platform? Does it meet the needs that you have in your daily practice? And how can we improve that platform so it's more like its use can be more sustainable and widespread in your daily activities. The methodology is multi-method. I'm not gonna go into details on that, but if you have questions, I'm happy to answer. So, dans le fond, ce qu'on veut vraiment, comme avec cette plateforme-là, puis j'en ai discuté déjà, là, mais c'est vraiment d'identifier les éléments clés d'une plateforme virtuelle qui fait de cette ressource-là une ressource de qualité qui va être vraiment utilisée par les médecins de famille, donc qui vont faire la promotion de cette ressource-là pour éventuellement qu'on soit capable de pallier à la pénurie de ressources au niveau de la santé mentale, de la prise en charge des problèmes communs de santé mentale pour les patients, puis évidemment, là, c'est spécifiquement pour la minorité francophone ontarienne, mais ça peut aussi informer la création de d'autres plateformes virtuelles ou d'autres solutions de soins virtuels pour différentes populations également. Puis c'est certain que c'est un projet, vu qu'on vise là, une population qui ont une iniquité au niveau de la santé, mais ça vise à réduire cette iniquité-là pour la population francophone ontarienne pour pouvoir vraiment faciliter l'accès aux soins de santé mentale pour cette population-là. Donc, voilà, ça fait c'était assez rapide là, comme overview. Si jamais vous avez des questions, n'hésitez pas. If you want to get involved, if you want to in any way, you have my email address there, and you can go and check the ēquilia platform if you're interested in learning more about that resource. Thank you for your attention, and if you have any question, feel free to ask.
Merci, Sophie. Très bien. You masterfully went from English to French. Well done. That was a great presentation and overview of what your proposed project's going to be. And I was really interested in sort of this three-step process. And I think that I think there's a tremendous amount of potential here. I think that, Zach has put an article in of an RCT for chatbots for mental health. There's a tremendous amount of promise here. So, this is good. Really looking forward to, hearing the results, of the study as it unfolds. I'm going to actually open the floor to questioning. Well, as people are thinking of questions, I'm going to ask you one, Sophie, and it is around sort of, you mentioned that you will have numerous, like your methods are going to be well set. I was just wondering, framing this, like anytime we're introducing new technology, there has to be, you're assessing that level of acceptance. And I was just wondering how you hope to frame this study.
I'm not sure exactly what you mean, but you mean like a satisfaction assessment?
Yeah, some sort of a framework. Like you're going to go into this, and you're going to sort of assess where its acceptance, how feasible it is, what the benefits, challenges, that sort of thing. And
right. So the framework for the research, yeah. So we use the technology acceptance framework. So just like making sure of acceptance throughout the process of creating those modules and improving those as well. So that's basically what we're aiming for, like usefulness and easy to use and all of that.
Excellent. Tried and true framework. It's been used with great success. So glad you're doing that. Go ahead, Owen. Yep.
I've worked in Merge many years ago, and it used to really bother me evaluating a francophone patient in the Merge department, particularly if it was bad depression and or any suggestion of suicidal ideation, because I didn't feel I was always doing a good job of getting an adequate history. Will this somehow improve that for a physician who might be working in a predominantly Anglophone region who's seeing a francophone patient who needs help now, 3 o'clock in the morning? What sort of resources are out there now?
I mean, if we talk about the program at the Montfort Hospital, I don't think it's like necessarily it will meet that need. But I know of different technologies that are being developed, like chatbots could help with collecting data for those patients and facilitating maybe the interaction. But yeah, the platform, I mean, except for just referring patients, there's no it's not an emergency resource, right? It's just really to help manage more long term. But I'm sure there's other technologies that can facilitate for sure. Like, I don't know if anyone else has any knowledge of that, but I think that AI-driven solution particularly could for sure help with navigating those interactions.
Zach, do you want to sort of expand on this tangentile?
Yes, this has come up just a couple times in that when you're trying to use technology for like a translation or to have bilingual services, that the French applications just aren't great for kind of Quebecois and Canadian French speakers. So I don't know what the solution to that is. I hope someone kind of makes one of these Canadian French language models, but I do see it as a bottleneck in a few different applications that I've come across so far.
Thank you.
You're right, at Quebecers, we have a different French, like we speak a little bit different. And the thing that's great with the ēquilia platform is that we have partnership with Sherbrooke. So we do have that perspective of Quebecers as well during throughout the research.
Well, if there aren't any further questions, Sophie, I'd like to thank you very much for this great presentation. And as I said, eagerly awaiting findings that come from this, and we'll have you back. And you can share those findings. In the meantime, we've got a couple minutes, so please remember to fill in your evaluations for this program. And we will look forward to, you can see a reminder of next Grand Rounds at the end of May on the 22nd. And we hope to see you all there. So once again, please fill in your evaluations, and we'll see you in May. Thanks to all our presenters today.